If you've been dealing with deep groin pain for months, pain that physio hasn't shifted, pain that gets worse if you sit for a long time or if you go from a seated to standing position, there's a good chance that this video is relevant to you. I'm Matthew Boyle, an orthopaedic surgeon in Auckland, and in this video I'm going to explain what a labral tear is, how it's diagnosed, and what the options are for treating it. The hip is a ball and socket joint. The ball is the head of the femur, the top of the thigh bone. The socket is the acetabulum, which is part of the pelvis. Wrapped around the rim of that socket is a ring of cartilage called the labrum. Think of it as a rubber seal. It deepens the socket, it keeps the ball centered, it holds fluid inside the joint, and it helps spread the load that goes through the hip every time you take a step. When the labrum tears, which can happen gradually or from a single incident, that seal is broken. The joint becomes less stable, the fluid dynamics change, and the surrounding structures start to compensate. That's where the pain comes from. Labral tears usually happen for one of three reasons. The first is femoroacetabular impingement, FAI. This is when the shape of the joint is not quite normal. Either there's extra bone on the ball, which we call cam morphology, or there's a slightly over-covering socket, which we call pincer morphology, or both. As the hip moves through range, these shapes clash at the rim, and over time this causes the labrum to tear. The second is hip dysplasia. This is when the socket is too shallow. It doesn't cover enough of the ball. The labrum ends up bearing more load than it should, and it tears as a result. And the third is trauma, a direct injury, a fall, a sudden movement. Less common, but it happens, particularly in athletes in high-demand sports. The classic symptom of a labral tear is deep groin pain, not the outside of the hip, the groin, sometimes described as inside of the hip joint itself. Patients often describe what we call as the C sign. They cup their hand around the front of the hip like a C shape when pointing to where it hurts. The pain is typically worse with prolonged sitting, with getting up from a chair, with pivoting, squatting, or impact activities. There's often a click or a catch with certain movements. One of the reasons labral tears are frequently missed or misdiagnosed is that the location is not where most people expect hip pain to be. Many patients are initially told they have a hip flexor strain or a groin strain, and they've often had months of physiotherapy directed at these structures before getting to the right diagnosis. If a labral tear is suspected, the first investigation is a plain X-ray, a standard AP pelvis X-ray, sometimes with additional views. Your GP or physiotherapist can request this. The X-ray won't show the labrum itself, but it will show the shape of the joint, whether there's a cam or pincer morphology, whether the socket is shallow, and whether there's any early arthritis. The definitive investigation for the labrum is an MRI arthrogram, an MRI where contrast is injected first. This gives a much clearer image of the labrum than a standard MRI. In New Zealand, an MRI arthrogram is arranged through the specialist after referral. It's not something that's typically requested in primary care. Treatment depends on the severity of the tear, the underlying cause, the patient's age and activity level, and how much these symptoms are affecting daily life. Physiotherapy is always the starting point. A targeted program that addresses hip strength, movement patterns, and load management can significantly reduce symptoms, and for some patients that's all that's needed. If symptoms haven't improved after a period of good physiotherapy, usually 3 to 6 months, surgery is worth considering. Hip arthroscopy is the surgical approach for most labral tears. This is keyhole surgery done through small incisions using a camera inside the joint. The labrum is repaired, meaning the tear is stitched back down to the bone, trimmed if the labral tear is partial thickness, or in some cases reconstructed. At the same time, any underlying bony abnormality is addressed. If there's a cam lesion causing the impingement, that extra bone is removed. If there's a pincer, the rim is trimmed. If dysplasia is the cause, then additional surgery such as a periacetabular osteotomy may be appropriate. Treating the cause, not just the tear itself, is what reduces the chance of it happening again. Recovery from hip arthroscopy takes time. In the first few weeks, you'll be on crutches to protect the hip while the labrum heals. Physiotherapy starts early, gentle range of motion in the first couple of weeks, progressing to strengthening from around 6 weeks. Return to light activity is usually around 3 months. Return to sport and heavy physical activity is typically 4 to 6 months, depending on how demanding the activity is and how the rehabilitation has gone. Most patients describe the pain improving steadily over the first 3 months, with strength and function continuing to improve beyond that. So to summarize, the hip labrum is a cartilage seal around the socket. When it tears, usually because of the shape of the joint or because of trauma, it causes deep groin pain that's often misdiagnosed as something else. The right starting point is a plain X-ray organised through your GP or physiotherapist, followed by a specialist referral if the pain is ongoing.